Now, benign prostatic hyperplasia is a big problem in us men as we age. So this red funnel represents the bladder, and this tube here represents the male urethra, 18 to 20 centimetres long. Now, in youth, the prostate gland is around about the urethra, just the same as it is in older life. So what you need to think of is the prostate gland surrounds the urethra. So the urethra is through here, and the prostate gland surrounds it. The urethra goes through the prostate gland, through the tissues of the gland. So the urethra is surrounded by the prostate gland like that. But in young men, say 20 to 30, even 40 to 45 years old, then there's no enlargement of the prostate gland, because the prostate gland starts enlarging at later life. 45 to 50 years it starts to enlarge. And then men in their 50s and 60s often start to experience the problems caused by the enlarged prostate. So in young men, the urethra is here. I've got some freshly collected urine. So the urine will flow through quickly and readily like that. No problem at all. And you can see that our toilet here is filling up with urine quite nicely. But as the prostate gland enlarges, it's going to squeeze on the urethra. It's going to be a pressure on the urethra. So now when we pour the orange in, when our urine tries to go through, there's a resistance, and it only comes through as a little dribble. So we get a much thinner flow compared to the sound that we get with a younger person's flow. Well, that's a nice flow with the patent urethra. Compared to the reduced dribbly flow in the older urethra. So here we see a rounded, fully patent urethra, as we might expect in a young person. But with increasing age, as the prostate gland enlarges, it squeezes on the urethra. And you can see that now makes it go much thinner and slit-like, making it harder for the urine to escape, giving rise to lower urinary tract symptoms. So the prostate gland enlarges with age. This is called benign prostatic hyperplasia. There's an increase in the number of cells present, and it's an increase in the number of the glandular cells in the prostate gland and the stromal cells, the neuromuscular cells, which are in between the glandular cells. Because this, of course, is the function of the prostate gland. What the prostate gland does is it adds part of the seminal fluid into the urethra, ready for ejaculation, so the sperm swim, partly in the prostatic secretions as well as other secretions produced by other parts of the genital tract. So the prostate gland is essential. We need it where it is, but as we get old it becomes a problem, because it's partly due to testosterone. The testosterone that men always produce is converted into dihydrotestosterone in the prostate gland, and that causes a stimulation and enlargement of the gland. And it will enlarge out the way, but it also enlarges in the way to squeeze the urethra. So the benign prostatic hyperplasia causes what we call bladder outlet obstruction. The bladder outlet obstruction. So BPH, benign prostatic hyperplasia, leads to BOO, bladder outlet obstruction. And the clinical features that we suffer from with this reduced stream are called lower urinary tract symptoms. So we notice with a normal sized prostate there's no significant pressure on the urethra and the urine flows through readily. No problem at all. But with benign prostatic hyperplasia there's pressure on the urethra, and now we notice that the flow of urine is greatly reduced because of the constriction of the urethra. and as we say, there's a reduced stream, and it's sometimes difficult to initiate urination as well, hesitancy, and there can be stopping and starting during the stream as well. It might take 2 or 3 attempts at urination to feel that the bladder is moderately empty, or sometimes the bladder doesn't feel empty even after urination. So urination occurs frequently because of the stimulation of the urine near the base of the bladder, this residual urine that's left in the bladder. And this also gives rise to urgency, where you just need to go to the loo immediately. Urgency, urgent desire to micturate, to void the bladder, to pass urine. The lower urinary tract symptoms, the LUTS, also include nocturia, getting up a few times in the night to go to the loo, because there's incomplete emptying of the bladder. Sometimes we need to strain to try and get the urine out, so-called Valsalva's manoeuvre. Particularly after the stream of urine, there can be residual dribbling, leading to a degree of urinary incontinence. And this can cause, as well as these inconvenient LUTS symptoms, there can also be quite serious complications. So, for example, we can get acute urinary retention, where the urine can't get out at all and the bladder will fill up, causing pain and distension of the bladder. There can be urinary tract infections, and particularly in more advanced disease, these become chronic urinary tract infections. Stones are more likely to occur, bladder stones are more likely to occur. There can be increased vascularity of the gland as well, and that can cause bleeding into the urethra, leading to hematuria. Although with hematuria we also need to think about other things such as prostate cancer or bladder cancer. Now, if it's very bad, if there's chronic obstruction, the bladder fills up, and of course the ureters are taking urine into the bladder. And after a period of time, the bladder can't contain all the urine, and the urine starts flooding back into the ureters. This is called hydroureter. And after a period of time, the urine can dam all the way back to the kidneys. That's called hydronephrosis. And hydronephrosis will lead to chronic pyelonephritis, infection of the kidney, destruction of the renal tissue, and complete renal failure. So you quite possibly, without treatment, someone can die of benign prostatic hyperplasia. So remember, the BPH leads to the BOO, leads to the LUTS, and it's all caused by this obstruction of the prostate gland, or the prostate gland obstructing the urethra. There are treatments for it. I mean, we can give some medications. There's medical treatments that can be given. The gold standard treatment is actually what we call TURP, transurethral resection of the prostate, where a diathermy is placed up the urethra to the level of the prostate gland with a cystoscope, and then the prostate gland can be paired out with cutting diathermy, heated cutting diathermy from the inside, and that gives very good results. So sometimes that sort of treatment is necessary. But you could say that this is the world's most common medical condition because it's going to affect all men. So if you're a man watching this video, I do hope you live long enough to develop benign prostatic hyperplasia, because in time you're going to. 80 or 90% of men in their 80s will have symptoms, becoming more common after the early 50s. Progressively more common as the prostate gland increases with age. Now, lower urinary tract symptoms can be caused by other conditions as well as benign prostatic hyperplasia, because benign, by definition, is non-malignant. And unfortunately, prostate cancer is the most common cancer in men. So there can be a malignancy in the prostate as well. Now, very often, the benign prostatic hyperplasia affects the parts of the prostate gland nearest to the urethra. So the lower urinary tract symptoms often come on fairly early in the disease process. Not necessarily so with prostate cancer. But it's true to say that prostate cancer can cause identical lower urinary tract symptoms to benign prostatic hyperplasia. So the difference between benign prostatic hyperplasia and malignancy of the prostate always needs to be diagnosed. One of the things we do is test for prostate-specific antigen. In all men, the prostate-specific antigen will increase with age, but in malignancy there can be quite a significant increase in prostate-specific antigen, the PSA test. But that is only a guide, of course. If the PSA was raised in combination with lower urinary tract symptoms, we need to palpate the prostate. So basically it's a glove finger into the rectum. The prostate gland is anterior, and in benign prostatic hyperplasia it can be palpated through the wall of the rectum, often enlarged. The enlargement can be felt, but the key thing is the surface of the gland feels soft, not soft, more rubberish. Feels rubbery, but it's smooth, it's not lumpy. Whereas in malignancy we can get bits of tumour which are lumpy sticking up, giving a lumpy feel to the gland, and especially hardness. If it feels hard, that's a stronger indication for malignancy, because tumours are irregular and they are hard if they are malignant. And then of course we would refer the patient fairly quickly straight away for a biopsy of the prostate, and then appropriate radiotherapy or surgical treatment, or whatever particular treatment the oncologist likes at the time to treat the malignant condition. At the moment, the results with radiotherapy for early prostate cancer are good, as indeed are some of the surgical options. So there's plenty we can do, but like all cancers, we need to catch it early. So hopefully most of you men watching won't get prostate cancer. There's nothing I can do to stop you getting benign prostatic hyperplasia as you get older. We don't really know what causes it. We know there's this hormonal cause, but I'm afraid I can't give you any specific advice to prevent it. But I would advise you a good diet and plenty of exercise, plenty of fruit and vegetables, because we know that things like tomatoes and a good nutrition will somewhat reduce the possibility of you getting cancer of the prostate, which of course is good. So with a patent urethra in a younger person, we notice that the urine flows out with a good stream, no problem at all. Whereas with the older person, because there is constriction of the urethra, we notice that the stream of urine is greatly reduced, might be intermittent, incomplete emptying, some dribbling at the end of the stream. Much more prolonged process for a lower total volume of urine being passed. Now this is probably one of the world's most common conditions. It's affecting basically all men as they age. So whatever field of practice you're in, you're certainly going to come across people with benign prostatic hyperplasia. Now we notice first of all that it's benign. This is not a cancer we're talking about. So a cancer will invasively spread and it will metastasize. This is benign. It will grow locally, but it won't metastasize. It won't spread tumours to other parts of the body. So it's benign. And it's prostatic because it's related to the prostate gland. And the prostate gland is producing quite a lot of the fluid component of the seminal fluid that carries the sperm to facilitate reproduction in sexual intercourse. And we notice it's a hyperplasia. Now hyper means high and plasia means to do with tissues, and literally this means an increase in the number of cells present. So it's not a cancer, it's affecting the prostate gland, and there's an increase in the number of cells present, an abnormal increase in the number of cells present. It's a hyperplasia. And there's proliferation of the cellular components of the prostate gland. Now basically there's two parts to the prostate gland. There's the glandular tissue, which is actually producing the part of the seminal fluid and exporting that. It's an exocrine gland. It's exporting that via ducts into the urethra. So there's the glandular component, sometimes called the epithelial component, because these epithelial cells are producing the exocrine product. And the other part is called the stroma, and the stroma is the tissue in the prostate gland which is not glandular. It's in between the glandular structures. And in the prostate gland, this is mostly fibromuscular in nature. It contains fibrous tissue such as collagen, and it contains muscle tissue which is primarily smooth muscle tissue. So there's these two components. And the hyperplasia in most cases mostly affects the glandular component. But there is increase in the number of cells in the stroma as well. And in a few rarer cases, the increase in the number of cells in the stroma is the main pathology. But in most cases, it's an increase in the number of the epithelial secretory glandular cells that is the main part of the problem. Now, the reason this is such a problem is the prostate gland is at the top of the urethra. So what we see here, this is the bladder, and this is the urethra going down here, carrying the urine out through the penis. And I've sketched out the prostate gland here in green so we can see it. And what we notice is that the prostate gland is surrounding the urethra. So if we imagine that that is the urethra, then the prostate gland is, the tissues are actually all round about it like that. They're surrounding it. The urethra is actually passing through the prostate gland. So that means if there's an increase in the size of the prostate gland, yes, it can expand out the way, but it will also expand in the way, and that will result in compression of the urethra. So we'll get compression of the urethra. That's the main problem with this benign prostatic hyperplasia. It's due to the anatomical arrangement of the prostate gland and the way that the urethra runs through the prostate gland. And of course, the only way that urine can get out of the bladder is via the urethra. So in this diagram, we notice that the bladder here, and there's urine going into the bladder via the ureters. And the bladder is storing urine until it's time to void it. And again, we see the prostate gland here that I've sketched out in green. And we notice that it surrounds the urethra. And we also notice that there's an internal sphincter and an external sphincter. So for urination to take place, there'll be some contraction of the bladder, relaxation of the internal and external sphincter, and the urine will simply flow out of the urethra, voiding the urine. But there's an internal sphincter and an external sphincter because the seminal fluid, when it's time to reproduce, will go from the prostate gland, through the tissues of the prostate gland, into the urethra there. And ejaculation will occur as seminal fluid moves from the urethra out through the external sphincter. And when ejaculation is taking place, we want the internal sphincter to contract. Otherwise, the ejaculate will go back into the bladder. So we have these two sphincters. But the key thing here is, again, we're noticing we have the urethra surrounded by prostatic tissue. And again, here we see a side view, we see the bladder. We notice that the rectum is posterior with the anus here. And again, we see that the urethra is going through the prostate gland before the urine carries on to the penis. And typically the male urethra is quite long, it's about 18 to 20 centimetres in length. Now in this diagram, again, we notice that the prostate gland is in green, but here we notice the ejaculatory ducts are bringing in sperm and part of the seminal fluid into another duct, two ducts, one on either side, the ejaculatory ducts. And these are bringing the sperm from the testes in to the prostatic urethra, but actually going through the tissue of the prostate gland. And we also notice in this diagram that the urethra can be considered in three stages. The prostatic urethra is where the urethra is going through the prostate gland. The membranous urethra is the next part, and then the spongy or the penile urethra is where the urethra is actually going through the penis. And this actually shows us the process of ejaculation and reproduction. So the sperm are coming up through the ductus vas deferens. Some seminal fluid is added from the seminal vesicles. Then the fluid from the seminal vesicles mixed in with the sperm is going through the ejaculatory ducts, and then the prostate gland adds more of the seminal fluid. This is what the prostate gland is doing. It's producing a lot of the liquid part of the seminal fluid that the sperm swim in prior to the process of ejaculation. Now, enlargement of the prostate gland causes LUTS, lower urinary tract symptoms. This is a big part of the problem with benign prostatic hyperplasia, lower urinary tract symptoms. And the prostate gland is going to start to grow in virtually all men in their mid-40s. So by the time men get to 50, there is some degree of prostatic enlargement. Now that doesn't always cause symptoms, it doesn't always cause these lower urinary tract symptoms, but the enlargement will be there. But the prevalence of lower urinary tract symptoms gets more prevalent with age. So men in their 50s, maybe about 8% are suffering from it. Men in their 80s and 80 plus, it's virtually all men are suffering from it. And there's a gradual increase between those two ages. So this is an age-related condition. It's getting more prevalent and more severe. The symptoms of the lower urinary tract symptoms are becoming more severe as men age. So the benign prostatic hyperplasia leads to bladder outlet obstruction. And that's what we saw, the urethra coming out of the bladder, the prostate gland surrounding it, the enlargement of the prostate gland squeezing that urethra inside. So the bladder outlet obstruction is what leads to the lower urinary tract symptoms. So BPH leading to BOO, leading to LUTS. Now, this is a picture I managed to find of me in my early 20s, I think. And as we see here, my stream of urine is good. There was no difficulty initiating the stream and flow of urine. There was a lot of pressure, so it went out a bit of the way from the body before going to the ground, and we see it's a nice thick stream. But in later life we notice that there's much less power in the stream. It's just coming straight down rather than going out and down. We notice that the stream is much thinner, and indeed that the stream is interrupted. Lower urinary tract symptoms. So lower urinary tract symptoms decrease force of stream. The urethra is no longer that wide, it's narrowed because it's being compressed by the prostate gland outside. So decreased force of stream. Hesitancy means it's difficult to initiate urination. Frequency and urgency means that urination is frequent, and urgency means that there is an extreme desire to pass urine all of a sudden sometimes, even despite the fact that there may be very little volume in the bladder to be voided. Nocturia is needing to get up overnight to pass urine. An incomplete bladder emptying means that even though the bladder starts to empty, the outflow obstruction caused by the enlarged prostate, the BOO, means that the bladder will not be able to empty properly, and that results in some residual urine being left in the bladder. As the condition gets more severe, the amount of residual volume will only tend to increase. Now sometimes there can be straining to void urine. This is the Valsalva manoeuvre. Valsalva manoeuvre is a forced expiration against a closed glottis, so it's that sort of straining thing to try and increase the pelvic pressure to facilitate voiding. There can be dribbling after a flow of urine has occurred, there's still some residual, so there's dribbling. And it can lead to acute urinary retention, AUR, but we'll look at that more when we consider complications of prostatic enlargement. Now, we can usually score this. The one I use is the International Prostate Symptom Score. This takes into account incomplete emptying as reported by the patient, frequency, intermittency. Intermittency is stopping and starting within the flow of urine. So urination will start, then it will stop, then it will start again. Urgency, weak stream, straining and nocturia. There are other ones. The American Urological Association I think has got a slight variation on this, but they're basically the same scores. And we can score these. Just download this from the internet. I'm not going to go through it in detail. It's readily available. International Prostate Symptom Score. So it's looking at those clinical features, how often they occur, and we get a score whether the condition is mild, moderate or severe. So download that form from the internet, try it on some of your patients and get a score to ascertain the severity of their condition. Now, what causes benign prostatic hyperplasia? Well, the stimulation for the cells to grow is probably largely caused by dihydrotestosterone. And this is a type of testosterone that is converted within the prostate gland itself from ordinary testosterone, which is circulating to the prostate gland just in the blood. So dihydrotestosterone is going to stimulate mitosis, especially in the glandular epithelial cells, but also, as we've seen, in the stromal cells as well. And there's also reduced apoptosis. It's believed there's reduced apoptosis. Now, apoptosis is programmed cell death, sometimes called cell suicide. So once a cell has lived for a period of time, performed its function, that cell will spontaneously commit suicide by autodigesting, this process of apoptosis. But if there's more mitosis being stimulated and less cells undergoing apoptosis, then clearly you've got more cells being produced, less cells committing suicide, so the number of cells is going to increase, and indeed that's what a hyperplasia is. And castrated males do not develop benign prostatic hyperplasia, providing they're castrated prior to puberty. So this indicates very strongly that this is a hormonal condition, as boys castrated before puberty do not get enlargement of the prostate. Not that it's a prophylactic strategy we're currently recommending. And here we see another diagram. This is the normal prostate here, with there's a prostatic capsule. The prostatic capsule is actually not that well defined. It's more or less continuous with the adjacent tissues. But we see a relatively small prostate, and we see a nice yellow large lumen of the urethra for urine to escape from. But here we see that there's this nodular enlargement, this hyperplasia. And the hyperplasia often starts in the periurethral parts of the prostate, the areas of the prostate around about the urethra. So it's going to press on the urethra very often at quite an early stage. So we see this enlargement here. We see that has compressed the outer prostatic tissue, and it also compresses the outer layer as well, forming what's called the surgical capsule, which is really compressed tissue from the expanding out the way. But of course we get expanding in the way, and we notice that the urethra is now very, very compressed. So instead of being nice urethra like that, it's all now compressed in the way like that, and there's only a slit left for urine to escape, a highly compressed urethra. And the enlargement is quite significant. A normal prostate gland weighs 20 to 30 grams, say when someone's 20 to 30 years old, but may increase with nodular hyperplasia to, it can be well over 100 grams, up to 150 grams, just with benign prostatic hyperplasia. So a significant increase in the size of the gland. It's not surprising the urethra becomes compressed. But nodular hyperplasia is not a precursor to carcinoma. Now, sometimes in the body you get what we call metastatic tissue. So this can occur in the cervix prior to development of cervical carcinoma. This can occur in the esophagus with a Barrett esophagus. We get this metaplastic tissue prior to the development sometimes of esophageal carcinoma. But benign prostatic hyperplasia is not a precursor to cancer. It's not a metaplastic tissue. Having said that, men still get prostatic cancer, of course. It's the most common cancer, but the most common cancer in men. But the point is, it's not caused by the benign prostatic hyperplasia, although the two conditions can clearly exist at the same time. So many complications of benign prostatic hyperplasia. Urinary tract infections are more common. Anytime you get stasis because the urine is not being easily voided, we can get urinary tract infections. That can lead to precipitation and bladder stones. There can be acute retention of urine where the person can't pass urine at all, and we have to admit these patients and catheterize them to allow them to void the urine. And if there's chronic retention of urine within the bladder, as those volumes increase, you start to get the urine going back into the ureters, causing hydroureter, and eventually back into the kidney, causing hydronephrosis, and that can lead to renal failure. And another point that's often overlooked is there can be hematuria because the prostate gland can become more vascular as well in benign prostatic hyperplasia. So hematuria is a possibility. Although of course with hematuria we also have to think about other possible conditions such as malignancy of the bladder. So diagrammatically, complications, we've got the enlarged prostate gland. We see they've got a very thin urethra now. The bladder has to strain to get the urine out, and that causes an increase in the muscularity of the bladder. The smooth muscle in the bladder will proliferate, and we can end up with strands of smooth muscle in the bladder. These are called trabeculations, overgrowth of smooth muscle. But the problem is, between the overgrowth of smooth muscle there can be weakening, and here we see a diverticulum has formed between the trabeculations. So the trabeculations are the hypertrophy, the increase in size in the smooth muscle cells, but there can be weakness in between, causing these blind-ended pouches. And the problem with these really is that the urine, even after voiding urine's always left in there, and that causes stasis, and of course stasis leads to infection. Bladder is dilated with increased residual volume, thickening of the bladder wall, and here we see if there's a lot of residual urine, then the vesico-ureteric valves, the valves between the bladder and the urethra, will fail. Urine will dam back up. Urine in the ureter is hydroureter. Urine in the kidneys is hydronephrosis, and over time that will lead to infection in the kidney and renal failure. So without treatment, this is a cause of death because it will cause renal failure. Diagnosis, how do we diagnose this condition? Well, we clinically assess the lower urinary tract symptoms. We can do post-void residual volumes of urine. So we ask the person to urinate, then we can do an ultrasound scan to assess how much urine is left in the bladder. And there's all sorts of flow rate measurements as well, where we measure the strength and the volume of the stream of urine as the patient urinates into a prepared vessel with sensors in it. Prostate-specific antigen. Now, prostate-specific antigen is actually part of the seminal fluid. It provides an important function actually in the process of reproduction, and it's produced by the glandular cells in the prostate. And if there's an increase in the number of glandular cells, then the PSA, the prostate-specific antigen in the blood, will go up. And this is also true in malignancy. There'll be an increase in PSA if there's malignancy or cancer of the prostate gland. So well worth measuring the levels of that. Typically it goes up a bit with age. With prostate cancer typically it goes up more, but it's only an indicator of course, but a very useful one. But a digital rectal examination with a simple gloved finger is very useful to palpate the prostate gland. So the finger's inserted into through the anus into the rectum, and the prostate gland is anterior. Now, benign enlargement, the gland typically feels smooth through the rectal mucosa, so if that's the rectal mucosa there, the prostate gland's just underneath. So if your finger's on top there, you can feel it. You can feel it through the rectal mucosa. So the benign gland typically feels rubbery and smooth, and very often you can feel the groove in it, the central sulcus in it. Whereas in malignancy, the gland often feels irregular, but it feels hard as well. Malignant tumours are hard and irregular. And any concern about malignancy, of course, we would consider a biopsy for full histological diagnosis. We can go on to medical management if the symptoms are a benign prostatic hyperplasia need to be treated, and we can give alpha-1 adrenergic receptor blockers. Now, the alpha-1 adrenergic receptor blockers are blocking. The alpha is part of the sympathetic nervous system, and it's blocking the constriction of the smooth muscle. Remember we said the stroma in the prostate gland contains a lot of smooth muscle, and there's also smooth muscle around about the neck of the bladder, particularly in the area of the internal sphincter. And if we block the sympathetic stimulation of those, then that causes relaxation. So that will relax the gland. It will reduce the size of the gland because the muscles inside the gland are now relaxed, and it will relax the muscle, smooth muscle around the neck of the bladder as well, improving urination flow. And if they're going to work, they typically work within about, well, they say a month, but it can be a bit longer than that. 4 or 5 weeks they normally start working. A second line of treatment is 5-alpha reductase inhibitors. Now, 5-alpha reductase is the enzyme that converts testosterone to dihydrotestosterone in the prostate gland itself. So that will reduce the formation of the dihydrotestosterone, which, as we said, is the main stimulus for the cellular proliferation and hyperplasia. But that one takes quite a lot longer to work. Some studies have shown that you get much better medical management by giving both of these medications. Surgical treatments work much better. The gold standard really that we still use most of the time is transurethral resection of the prostate, where a cystoscope is passed up into the urethra and a heated diathermy wire loop is used to pair off the prostate gland from the inside, and that also allows us to take samples of the prostate gland for biopsy as well. But our surgical colleagues are always thinking of new ideas. I mean, for years we have used open prostatectomy, but not very often. Open prostatectomy is an open surgical procedure to remove the prostate gland. But they're now developing laser therapies, stents, balloon dilations, where a balloon is passed up into the prostatic urethra and dilated. So various surgical options for treatment. So basically we see that we're dealing with perhaps the world's most common condition, that all men, if they live long enough, are going to get prostatic hyperplasia. It occurs in white men, probably more common in African American men. Epidemiology has been done in the States. Less common in Japanese men for some reason. So there is some slight racial differences. But basically, as men age, the variations in the testosterone are going to cause enlargement of the prostate, giving rise to bladder outflow obstruction and lower urinary tract symptoms.